We will meet again Professor Vidan for the new topic talk about the FairEmbo. Yes, please, Professor Vidan.
Hello, I'm really happy to share with you these presentations about FairEmbo and the possibility of arterial embolizations with permanent and absorbable sutures. Thank you again for the invitation to your Congress. So the ultimate goal, I think, of all interventional radiology is to provide the best care to even our most vulnerable patients. And which are some symptoms and some tragedy that we can do something, where we can do something. It's clearly car or bike accident with trauma and postpartum hemorrhage. In this case, embolizations of the pelvic is really, really helpful for people who are healthy. It's not old people with cancer, it's really people which are young. If we look at the health access and quality index, we see that this map is almost the same map that the life expectancy. And if you live in a blue country, you have a life expectancy which is really high. But of course, if you live in a country which is more red, the life expectancy can be low as 45 to 50 years. If you look at the maternal mortality, it's almost the same map. And that means that where you don't have the care, of course, you have a maternal mortality, which is really high. In France, it's around 80 per 100,000 births. In Senegal, for example, it's around 200. So is it a fatality, these things? Is it a trouble of access to formations and training? Is this a trouble of access to X-ray and ultrasounds, or it is a trouble of access to medical device? This is very interesting, because why interventional radiology is not enough developed in some emerging countries. If we look to access to formation and training, there is a lot of local strength. I'm sure in Vietnam there is a lot of strength. In other countries that we are visiting, like Senegal, for example, we are working a lot with Senegal. They are very good interventional radiologists. They have had good formation. They have done the fellowship in France or in other countries. There are also a lot of possibility to do some educational program. There is, for example, Road to High Hair, which is led by Fabian Lag-Gaube in Yale, and which give a lot of formations. So of course, formations is important, but there is a lot of possibility of formations. Is it a problem to access to X-ray and ultrasound? This is a really modern interventional room, which can cost a lot, but with this device, which is X-ray and screen, you can do a lot of things. A lot of things, that means you can do, for example, pelvic embolizations. So you don't need cutting edge technology to save life. In many countries, in many emerging countries, interventional cardiology can share the room with the interventional radiologist. And it's good, I think, because the basic tools like wire, catheter, sheet, introducer, all these kind of things are some things that you can use both in interventional cardiology and in interventional radiology. If there's a problem to medical device, access to medical device, then it's very interesting, because in a lot of emerging countries, these devices, which are embolic devices, are not distributed by the company. The big company have no network of distribution in this country, because they argue that the economic work is not enough to have this network. So usually these devices are difficult to find, And when you find them at a very high price. That means that, for example, sphere, a vial of sphere in France is around 300 euros. In Senegal, it can cost around 1,000 euros. So in an emerging country, you have the cost of a device which is 3 to 4 times the cost in France. It's completely crazy. So of course, some of the devices like gel foam can be very cheap, but some of the other devices can lead around 300, 400, 500 euros. So is it a problem? Yes, clearly it's a problem. When you have an interventional radiologist, which have the skill, when you have the X-ray, when you have the patients who bleeds, and you don't have just the things to put in the artery to block the artery and do the hemostasis, it's a big deal. So with Jafar Goldarian in Egyptia, we was thinking about doing something which is high quality and low cost. But low cost is interesting, but we don't need to be inside the circuit of the medical device because it will have the same troubles. So we was first thinking to use hydrophile cotton, because hydrophile cotton you can find everywhere and it works. We have done a lot of experiments, but it leads to adenopathy, inflammations, and it is not the best tool. So from the cotton, we go to another point of, we was thinking of thread of cotton. So was thinking of thread of sutures. You see, this is one of the first draw of vascular suture, which come from French surgeons in Lyon, in France. And every day, surgeons insert sutures in the artery. This is the sutures of aortic valve. And you see here the suture which stay in the artery. So we said, okay, we can inject directly sutures. If you look at that, this is a torpedo of gel foam, and this is a fragment thread of sutures. You see the size and you see the aspect. It seems to be clearly the same. This is completely resorbable, and this is resorbable or not resorbable, and you have different size, and it's sterile, and you have some in all the hospital on the earth. So clearly it can be a good tool. We have looked the compatibility of the size of the thread of sutures with the catheter. So you can have such thread of sutures, we can go in microcatheter, but also in a whole the catheter. So it's very easy to use. So we have published the first paper in Sevilla in April 2019 about the concept. And the concept, we have done experiment on pigs on acute and chronic setting. So on the protocol, we have CT scanner, angiography, histological study, and we have done embolizations of pharyngeal, mesenteric, kidney, splenic artery. We have done all these embolizations. So for example, splenic here, the catheter is here. We have put the thread of suture here in blocks, here on the kidney. So we have looked about the technical success and the non-target embolizations risk. On the chronic groups, we have kept the pigs for 3 months, and we have done embolizations with absorbable and non-absorbable sutures. So you can see here, day 0, M3, 3 months, we have embolized both the inferior polar or kidney on the right and on the left with absorbable suture. At 3 months, all the embolized artery with absorbable suture we will repermeabilize. It's interesting because in the non-absorbable suture, the arterial embolic material were always there, and there is nothing in the absorbable suture. All the material has been reabsorbable. There is no inflammations, no perivascular granulocytic infiltration around that. So when we have done the first experiment, we said this can be useful, this thread, to do embolizations like coils. We said, okay, it will be a big deal to do a non-spherical particles. With non-spherical particles, you can treat benign tumor, like fibroid, which is, for example, a big deal in Africa. You can treat malignant tumor to do blunt embolizations. So this is the thread that we have cut with scissor. You see here the cutting, you can be cutting a little bigger or a little smaller. So we have done a study around that we have published also in CVIR. We have looked at when you ask people to cut as small as possible with scissor, they cut around 900 micron, and this is the repartitions of the sphere. So you see the repartition of the sphere, the different operator, which are not medical doctor, which are only people who do the cutting. So there is a good reproduction of that. And you see the sphere here in the syringe, here at the lab, where we are doing the experiment on pigs. So we have done embolizations of classical sphere of the market, Ambozen 900, versus our first sphere, which we have done with thread of sutures. So here is the result. So you see the embolizations of upper pole of the right and left kidney with both sphere. So here you see the infarction of both kidney. And here you see in purple, it's Ambozen sphere. And here in blue, it is a suture sphere. So this is Ambozen, which is spheric, and this is first sphere, which are not spheric, of course, because they are cut in the biggest part. This is the length, you see, 600 by 300, which is the diameter of the thread of sutures. So you can see here Ambozen, here suture sphere, and this is on the before embolizations and 3 months after embolizations. So there was no difference on the 6 pig about the perfusion defect on DSA, the cortical atrophy, the volume of the kidney. The result of embolizations was the same. We have no infiltration, no inflammations. The only point, of course, is the time of the procedure is longer with the sphere than with Ambozen, because when you use a sphere, like you use a PVA, it takes more time to do the percolations of the sphere inside the catheter to avoid to have a blockage of the microcatheter. So where we are now, on the ethical committee, we know that the toxicity of this suture is very well known. It has been inserted in every country, although endovascular implantation of suture is okay. Most important, it has been already done and already published, and especially with a thread of silk sutures. So anyway, it has been already done in patients. What is the advantage or disadvantage of that? The advantage, of course, is low cost. It's available worldwide. It's very easy of use. You just cut your thread of sutures and you percolate in the catheter. We know about the long-term safety. The disadvantage is the linear shape. It's not like coils. You don't have a sphere, a form, a coils, which can clearly block at a part of the artery. But when we look at what we have done experimentally, it blocks really closely, like a torpedo, gel foam torpedo. And of course, it's not radiopaque, such as particle and gelatin. So either the clinical impact for patients, yes, of course, because exsanguinations within the first 24 hours after delivery or post-traumatic abdominal pelvic hemorrhagic wounds has a very high mortality. We know that. So if you have just a needle, a wire, a 5 French catheter, and 3 sutures, you can do that. It's not a lot of device. That's why I said. So the first clinical case which has been published 2 years ago by the team of Professor Diop in Senegal. So this is a perfect example of what can be done. It's embolizations of a life-threatening bleeding. This is a false aneurysm of the kidney, with a huge retroperitoneal hematoma, hemodynamic shock. So Professor Job insert a 5 French catheter here. He can go to the place where there is the bleeding. He just insert 4 fragments of 1 centimeter of non-absorbable suture, polyamide monofilament, and he had a complete occlusion of the targeted vessel in 3 minutes with clinical recovery. Now, they have done plenty of other patients with that, but this is the first case which has been published. So here, again, for the material which has been used, we have only 1 needle, 1 5 French catheter, and 4 fragments of sutures. And the bleeding is treated. So clearly, I think so. So this is our consortium. This is the team we have working with in Cambodia. This is Senegal. Here are the countries we are involved right now with FairEmbo. There are plenty of patients working. For example, Gisoulez, which is from the University of Montreal, from Job from Senegal, Gloria Salazar, which is really helpful from Harvard, which works with us on development. And very interesting, the paper that Yaswa Kiare has written about interventional radiology for womb. Of course, FairEmbo is one of the key to save life in emerging country. And I think the conclusion of the paper say our high interventional radiology should not be just for the wealthy. We should look to cheaper high hair to make high hair loved by everyone on the planet. And clearly, I think we can reach this goal. So one of our medical doctor is actually in PhD working on that. And it's really important because we are working on sphere and we want to have a sphere which are more regular to do fibroid embolizations, for example. And this is the beginning of, we are working with engineer school, which are working on a device which is going to cut the thread at a regular size, 500, 600, or 700. So this tool will be less than 500 euro, and we can give this tool to a medical center, for example, in Dakar. So the day before the intervention, of course, it's not for emergency, it's for malignant tumor, benign tumor. You can cut the thread, you put the thread in a small bag, you put it at the sterilizations in autoclave, and the day after you can use the sphere as normally with other sphere. So what we can say today for FairEmbo and embolizations with absorbable suture and non-absorbable suture is feasible, it is safe, and it is effective. So I think clearly we have here an inexpensive and widely available embolization agent in hospital worldwide. Again, we have spoken with a lot of economic partner, especially in emerging countries. It's really important to know that interventional radiology for this kind of procedure are cheaper than surgery and other things. It's cheaper to do an embolization of the uterus for postpartum hemorrhage than doing an hysterectomy. If you do an hysterectomy, you will have a follow-up stay at the hospital, which will be around 10 days, and the patients will have no more uterus, and doing the embolizations is really quicker, cheaper, safer. So I'm quite sure that we can go really further with embolizations in emerging countries, and I am really happy to participate, and I will be very happy to come to Vietnam if necessary and if I can help. So thank you.